I want to tell you about a patient I'll call Christy. Christy is 47. She has what her doctors describe as a few things going on. Her blood pressure started creeping up, runs a little high. Her blood sugar came back pre diabetic. She's gained weight in the last few years, mostly in her midsection. She's tired in a way that sleep just doesn't fix. She thinks perimenopause explains most of it. Christy has seen 4 different doctors in the last 2 years, a cardiologist for her blood pressure, an endocrinologist briefly for her blood sugar, her OB for hormone therapy, and her primary care doctor, who's doing her best to hold all of this together in 15-minute visits. Nobody has told Christy that these are not separate problems, and it's not all perimenopause. The timing, 47, perimenopausal, weight shifting to her middle, is not a coincidence. Today, I want to tell you 3 things. Okay, number 1, cardiovascular-kidney-metabolic syndrome, CKM syndrome, what it is, and why 90% of Americans have at least one risk factor. Number 2, why this presents differently in women and kills them, us, at earlier stages. And number 3, what you can do about it. Let's get into it. This month, a bunch of societies got together, and the American Heart Association released the first ever clinical guideline for something called cardiovascular kidney-metabolic syndrome, CKM syndrome. What it says, formally, officially, and for the first time, is that your heart, your kidneys, and your metabolism, these are not separate systems. They are one connected system. The conditions we think of as separate, like obesity, type 2 diabetes, chronic kidney disease, high blood pressure, heart disease, these aren't 5 distinct diagnoses that happen to show up in the same person. These are expressions of one loop of dysfunction that medicine has been treating in pieces. Christy doesn't have 4 problems. Christy has CKM syndrome. The guideline stages this 0 through 4. 0 is no risk factors. 4 is established cardiovascular disease. The stages in between capture the progression, and the point of staging is intervention. So the earlier you identify where someone sits on this spectrum, the more you can do about it. Nearly 90% of US adults have at least one CKM risk factor. This is the defining chronic disease challenge of our time. The new guideline is important. It also has some caveats, especially for women, which we should absolutely talk about. Let's start with why it took until 2026 to get here. So medicine is organized around organs. You have a heart problem, you see a cardiologist. You have a kidney problem, you see a nephrologist. A metabolism problem, you see an endocrinologist. These are separate specialties with separate training programs, separate billing codes, separate professional societies with separate conferences and separate guidelines. But our bodies aren't organized this way. Our bodies don't care that a kidney doctor doesn't go to a cardiology conference to learn what he needs to know about the heart. Here's what the loop looks like at the biological level. And bear with me, this is like our science part, okay? So it starts often with insulin resistance and excess visceral adiposity. That's fat around the organs, which is not inert tissue. This fat is metabolically active. What does that mean? It secretes inflammatory cytokines. It promotes oxidative stress. It damages the endothelium, which is the lining of your blood vessels. And the endothelial damage accelerates atherosclerosis and stiffens arterial walls. Elevated blood sugar compounds all of this. So chronic hyperglycemia injures the microvasculature, including the glomeruli in your kidneys. Filtration efficiency drops, and when kidney function declines, fluid and pressure regulation go with it. Okay, so here's where it gets even more interesting. Cardiac dysfunction triggers the renin-angiotensin-aldosterone system, the RAAS, which increases peripheral vascular resistance, promotes sodium and water retention, and damages the glomeruli even further. Impaired kidneys then drive up blood pressure, which increases the cardiovascular workload and worsens insulin resistance and dyslipidemia. Each system is making the others worse. chronic inflammation, oxidative stress, insulin resistance, RAS activation, neurohormonal dysfunction, lots of organ systems, and decades of medicine treating it as kind of these like different distinct diseases. Treating them separately also meant that a single doctor is usually not owning the whole picture. So for Christy, nobody was quarterbacking Christy's care. The cardiologist managed her blood pressure. The endocrinologist flagged her blood sugar. Nobody really said, these are all part of the same story. CKM gives medicine a framework for that. And amazing. That's a step forward. Here's what I want every woman in her 30s, her 40s, and 50s who's watching right now, hi, to understand. Christy's timing is not a coincidence. Let's talk about estrogen. Okay, estrogen does a lot of things in the female body that we don't fully appreciate until that estrogen starts to decline. We'll talk about a lot of them over some videos, but related to CKM. Okay, so estrogen keeps blood vessels flexible and responsive. Estrogen helps regulate insulin sensitivity. Estrogen influences how and where the body stores fat. Estrogen has anti-inflammatory effects on the cardiovascular system. As estrogen declines in perimenopause, and this process, as all of us know, it can start years before the last menstrual period, a cascade of cardiometabolic changes begins. Published research from 2025 documents what happens. LDL cholesterol rises, HDL drops, triglycerides increase, insulin resistance worsens, and visceral fat, that fat around our organs, can double or triple during this transition. I have a number of patients for whom a rise in LDL was one of the first signals that they were in perimenopause. These are not just symptoms of getting older. Research shows that these changes occur beyond what chronological age would predict. The menopause transition itself accelerates cardiometabolic risk. A paper published in late 2025 put it plainly. Menopause is a critical window for CKM syndrome prevention. Not because menopause causes CKM syndrome, but because the hormonal transition removes biological protections that were quietly doing a lot of work. And now the underlying vulnerabilities become visible. Christy's weight shifting through her midsection during perimenopause, her blood pressure creeping up, her blood sugar tipping toward pre-diabetic. These are all connected. They are CKM signals arriving at a biologically predictable moment. These are exactly the signals that a system built around separate specialists, separate appointments, separate guidelines is most likely to miss. I want to say something about weight here too, because the guideline uses BMI, and I think that deserves some pushback. Because BMI does not tell you where weight is distributed in your body. Where it's distributed is actually what drives metabolic risk, that visceral adiposity. It's far more metabolically dangerous than fat elsewhere. Research on sex differences in CKM specifically shows that this risk is disproportionately greater in women. Two women with identical BMIs can have completely different CKM risk profiles depending on where they carry their weight. So if a doctor checks your BMI, says you're in normal range, and moves on, that is not the complete picture. The question is not just how much you weigh, it is where that weight sits and your metabolic markers and what they look like underneath that weight. Okay, I need to tell you something else important about women specifically, and I want to be precise about what we know and what we don't. There's a separate research brief published in the journal Circulation in 2025, distinct from the guideline we've been talking about. It analyzed 30 years of US CKM data by sex. Amazing. Also not a surprise. It found something striking. Okay. Women are less likely to reach advanced CKM stages than men. Men get sicker sooner on the spectrum. However, once a woman has CKM syndrome, at any stage, her risk of dying from it is higher than a man's at that same stage. Men get sicker, and women die more. The pattern of disease also looks different by sex. In men with advanced CKM, the dominant subclinical finding is atherosclerosis, plaque building up in the coronary arteries. This is a classic presentation, right? The Hollywood heart attack. In women, though, the more common subclinical finding is heart failure. The heart muscle straining, stiffening under pressure, all before recognizable symptoms appear. Different disease process and a different thing to test for. And so a system trained on the male presentation may look for blockage, and it may miss what's actually happening in the cardiac muscle of a woman. To be honest, we don't fully understand why women's mortality risk is higher at earlier stages. And the researchers say that. A review in Biology of Sex Differences last month, it noted significant knowledge gaps remain, right? And that evidence-based clinical action plans for women specifically are still missing. This guideline is built primarily on data from male dominant trials. That is the historical pattern in cardiovascular medicine and all of medicine for that matter. At the McKinsey Health Institute, we found that only 10% of heart disease trials publish sex disaggregated data results, meaning that 90% of trials did not publish how the trials affect women uniquely, specifically, or differently. The women's data are admittedly lacking, or sometimes they arrive in separate publications. You know, more recently, we're seeing more, but overall, they're just not fully integrated into the primary evidence base. So for CKM, the framework now exists. The chapter on women is still being written. Now, I don't want to leave you with just a problem. So let's talk about some solutions, right? What can you do? So most important, CKM syndrome is not a one-way door, right? The guideline and the clinical literature here, they're explicit about this. In the earlier stages, stages 1 and 2, lifestyle interventions can not only stop progression, they can actually help you regress to earlier stages. You can move like backwards on the CKM spectrum. So what does that mean? Diet, physical activity, behavioral modifications. These are not like soft suggestions. These are actually things that you can do that have benefit. So a JACC expert panel published this year reviewed the randomized trial evidence specifically for lifestyle interventions across CKM stages. It found meaningful effects at every stage, including on cardiac stiffness and early heart failure patterns. 1 year of committed exercise training has been shown to reverse abnormal left ventricular stiffness in patients with early heart failure. That is not nothing. And the newer medications we all know about, they also matter. GLP-1 agonists like semaglutide and tirzepatide, SGLT2 inhibitors, newer kidney protective agents, and the CKM framework, it's specifically designed to identify who needs these meds and when across the whole system, not just one piece of that system. So the goal of staging, it's not to give you yet something else to worry about, right? It's to give your doctor a starting point for intervention before you get to stage 4, before the heart attack, while there's still a lot that we can do and change. The guideline recommends the PREVENT equations, predicting risk of cardiovascular disease events. PREVENT, okay, to estimate 10 and 30-year cardiovascular risk. It was updated to be more accurate for women, and it incorporates kidney function. So guess what? It's better than what came before. Your doctor should also incorporate your reproductive history into your CKM evaluation. If you have had a pregnancy complication, gestational diabetes, preeclampsia, hypertensive disorders of pregnancy, a small for gestational age baby, these are early CKM signals, and most women are never told that. That conversation belongs with your primary care doctor, not your OB. And a one-time mention at the 6-week visit doesn't count, right? So if you have PCOS, now PMOS, this is also a cardiometabolic condition, not just a reproductive one. Your long-term metabolic risk should be tracked longitudinally. If you're in perimenopause or postmenopause and your blood pressure, your blood sugar, your weight, or your kidney function has shifted at all, even mildly, even with the let's just watch it language, this is your window. Ask for it to be looked at as a whole picture and what to do about it. So the question I would ask is has anyone looked at all these together? Has anyone staged my CKM risk? Has anyone run a PREVENT score on me? These aren't demanding questions, right? Like these are the right questions to ask. So, um, there's one more thing I want to mention, and I'm going to give it its own, I guess, episode because it deserves the full story. So, one of the things that happens as CKM syndrome progresses, especially during and after the menopause transition, is that blood vessels get stiffer. The same process we've been talking about: metabolic stress, hormonal change, and vascular aging. That stiffness shows up somewhere you might not expect. It shows up on your mammogram. There's a finding called breast arterial calcification, BAC, that is present on somewhere between 13 and 30% of routine mammograms. It is a marker of arterial stiffness, and it is a cardiovascular risk signal. And it is routinely not reported. In fact, 95% of the time, it's not reported, it's not explained, and it's not acted on for reasons that have everything to do with how the healthcare system was designed and very little to do with the evidence. So that's the next episode. Okay, so 3 things. Number 1, cardiovascular kidney-metabolic syndrome, CKM, is one interconnected disease process. It's not 4 or 5 separate diseases that happen to share a patient. Medicine has now built a framework to treat it as if it is interconnected. Number 2, in women, CKM presents differently, it hides better, and it carries higher mortality risk at earlier stages than men. The research to fully explain why is still catching up, but the signal is real, and it is in the data. And number 3, CKM is not a one-way door. Regression is possible. The perimenopause window, like now, right? This is when the underlying vulnerabilities become visible, and this is when intervention has the most to offer us. So back to Christy, she went in for anal physical last month. She got her blood pressure checked, her blood sugar checked, her weight, for lots of referrals, lots of different specialists, right? Nobody ran a prevent score, nobody staged for CKM risk, and nobody said, Christy, these are not separate problems. They are one, and we are in the window right now when we can actually do something about it. Medicine has built this framework to have that conversation now. That's great. What we need is for that conversation to actually happen. And you don't have to wait for your doctor to bring it up. You can bring it up yourself.